Yeah, that's right. Okay, sure. First of all, thank you, Aditya, for the kind invite. And of course, after an excellent talk by Dr. Kokar sir, what I'm going to talk to you about is going to be what is basically the current knowledge about pediatric keratoconus. Pediatric keratoconus itself is a trending topic because I think initially we were not really differentiating between adult keratoconus and pediatric keratoconus, but for a variety of reasons, pediatric keratoconus is special, and we'll come to that. We all are aware that keratoconus is a progressive asymmetric disorder with stromal thinning, irregular astigmatism, many times less than 18 years. Yeah. The youngest age, 4 years. I mean, it has been diagnosed earliest in the 4 years. Yeah. Anybody who is less than 18 years, because they do behave differently. That's the thing. I mean, yeah. So the youngest one, which is currently diagnosed to have, is 4-year-old with the Down syndrome. Yeah, yeah. Yeah, so basically we all know about adult keratoconus pretty well, as I'm very sure. And of course, the diagnosis is, we are well aware about it. The mainstay of diagnosis is, of course, the corneal tomography, and in current generation corneal tomographers such as Pentacam and Cirrus. The corneal epithelial maps are actually adding to the advantage of early detection of these patients. But the most important thing for us to know is that in majority of the keratoconus patients, the studies have shown that the mechanisms have started to get sets in around puberty, but the clinical manifestation is variable. In majority of them, it is seen in the second decade of life. But there have been special situations where the pediatric keratoconus was already we were very well aware of, and one of them was in Down syndrome. We already know that Down syndrome has a great keratoconus as a comorbidity, and it has been reported many times, especially by large-scale studies by AIOC et al., that the patients who have Down syndrome are more likely to represent morphological abnormalities compatible to keratoconus. Of course, the data is still quite variable, but it is proved beyond doubt that keratoconus in patients who have Down syndrome is known to be more aggressively progressive. And the case report, which is as early as 4 years of age in patients who have Down syndrome, actually presented with eye drops. So immediate treatment is required for patients who have Down syndrome. It's also mandatory to do a detailed corneal workup to detect keratoconus earlier. So why are we talking about pediatric keratoconus separately? Is it similar to adult keratoconus? Of course not. Now, pediatric keratoconus is a completely new entity because we all know that pediatric keratoconus behaves differently. We know when the keratoconus starts in younger age group, the weak ectatic lamella, they exceed the capacity of the age-related natural cross-linking. Therefore, the progression is known to be much faster. The studies have reported that there is a 7-fold higher risk of needing corneal surgeries in pediatric patients as compared to the adult patients. And in comorbidities such as when you have atopy or vernal keratoconjunctivitis, the progression is known to be much faster, and long-term complications are known to be much more. There is a very good long-term study done by Joseph Colin et al., who is one of the pioneers of INTAX, and they have seen that at diagnosis, the keratoconus is often more advanced in pediatric patients. 30% children and adolescents have stage 4 keratoconus at diagnosis, as against only 8% when it is diagnosed in adults. 88% of these pediatric patients are known to be progressive in a very fast scale, when the steepening within 1 year is more than 2 diopters. And the unaffected eye is also known to develop keratoconus in variable time in about 35% of cases. The CLIC studies have also shown that in age between 10 to 20 years, this is the prediction for the significant progression and later on to have corneal scarring. So whenever we see a patient of keratoconus in the adults, it is proven beyond doubt that the collagen cross-linkage is the mainstay of treatment to stop the keratoconus from progressing. The current stage or the current method that we use for cross-linking is called as a Dresden standardized protocol, in which first you actually remove epithelium by variability of methods. After that, you instill riboflavin for about 20 to 30 minutes, and you use a 3 milliwatt per centimeter square energy for about half an hour. So this was the first ever proven method of stopping keratoconus or halting its progression. This was the brainchild of Theo Zahler's group. and especially Spohl et al. And Wolensak, both of them had contributed a lot. So in the early stages in 2003, when the early human trials were started, the cross-linking had shown that it stops keratoconus progression, increases biomechanical stability of cornea, and it causes resistance to enzymatic digestions. So basically, cross-linking works with the help of riboflavin, which gets excited with ultraviolet radiation. And when you have this production of activated oxygen radicals, they cause cross-linking between the collagen fibers. And as you can see here, as against in the cornea, which is keratoconic, when you undergo cross-linking, it becomes much more stiffer, and the Young's modulus is known to increase by about 4.5 times. Now, there are a variety of studies, that I think more than 1,000 publications demonstrating the safety and efficacy of the cross-linking in adult population up to 10 years. But what about pediatric cases? Does it work as well? So there have been a variety of studies which have looked at between 1 year to 10 years of follow-up after cross-linking. And one of them, which comes from India, is from Ritu Arora et al. And they have shown that up to 1 year, the collagen cross-linkage by Dresden protocol was seen to be stabilizing keratoconus with no significant complications. This study by Toprak et al. Had demonstrated that up to 2 years, the keratoconus was stable in their set of patients. And it also demonstrated that it was showing a progressive improvement in both their keratometric as well as the topographic indices. When it comes to the progression of keratoconus and its efficacy of cross-linking in children and adolescents, this study by Hafezi et al., who does a lot of work on keratoconus, especially pediatric keratoconus, demonstrated that up to 3 years of outcomes were actually very, very encouraging. They had 52 eyes of 59 patients who were enrolled in this study and demonstrated progression before they did cross-linking in 88% of them, which is a very high rate of progression. 46 eyes underwent cross-linking, and they have shown that up to 2 years, there was a significant reduction in Kmax, and there was a good stability of keratoconus. The study also demonstrated that we should perform cross-linking at diagnosis for pediatric keratoconus as against in adults, where we actually wait for documented progression, because very high rate of keratoconus progression is seen in about 88% cases, which is very high. The arrest of the progression might not be long-lasting. This is very important as against in adults. And in their series as well, one eye had to undergo transplant because of persistent progression in spite of undergoing cross-linking. When we look at even more long-term studies, which are more than 4 years, Dr. Prema Padmanabhan et al. From our alma mater from Shankar Netralaya demonstrated that cross-linking is effective in stabilizing keratoconus for longer than 2 years and up to 4 years. However, they saw that at 4 years, 24% eyes demonstrated steepening, and almost 80% showed stabilization, but 20% of them actually came into the diagnosis of further progression and required treatment. So it does demonstrate that whether the cross-linking does work in pediatric cases, definitely, but the stability is not seen to be very long-term. It is about 80% of these patients show stability up to 10 years. Now, this is a very important study by Cosimo Mazzotta et al. From Italy. He is also one of our collaborators, and we do a lot of collaborative research work together. This is one of the longest term follow-up which is available today for cross-linking in pediatric cases. They demonstrated that up to 10 years, although the stability was seen in about 80% cases, 24% eyes demonstrated progression in variability of amount, and 20% of them were really truly in the picture of progression. And 2 eyes required corneal grafting as well. However, they did demonstrate that the coma aberrations, which demonstrated improvement after cross-linking, were actually maintaining its benefit even in long term up to 10 years in all the cases. So we do know for sure that cross-linking does work in pediatric patients as well, but we have to still look for the follow-up of progression as well. Now, this is a new concept which is coming, which is called as a CXL+. This is the concept by one of my mentors, Professor Quinones. So basically, we all know that many patients who undergo cross-linking, even in adults, they are very stable, but many times they cannot see because they have very poor vision because of the irregular astigmatism. Sometimes they cannot even tolerate contact lenses. That is especially true also in pediatric patients. So in those patients, we combine cross-linking with variety of visual rehabilitating procedures such as topo-guided PRK called as Athan's protocol, PTK, which is called as the Kredan protocol, Intacs and phakic lenses. Of course, in adults, whenever we see a patient who is having relatively good spectacle corrected visual acuity. Out of these 4 entities, there are 2 which actually are very useful for pediatric cross-linking. One of them is the Craton protocol, second one is the Intax. We avoid doing Athens protocol in keratoconus, pediatric keratoconus, because they are known to be more aggressive. But the Craton protocol works beautifully well, and we have completely shifted to it. So I'll just come to the concept of Craton protocol. We all know that mechanical removal of corneal epithelium is an essential component of cross-linking now, and epithelium must be optimally removed to allow adequate penetration of both riboflavin as well as the UVA light as well. The million-dollar question was that because we have variety of methods of epithelial removal, can the method of epithelial removal itself help us in improving visual outcomes of these collagen cross-linking patients? We all know from this study by Dan Reinstein that the epithelial thickness in keratoconus is not regular, but it is known to actually showcase what is called as a donut pattern. That means the epithelium at the apex of the cone is known to be very thin, and as we go to the periphery, the epithelium becomes thicker and thicker. So to take advantage of this knowledge, as you can see here, this is the very high frequency ultrasound which shows the epithelium at the apex to be only 38 microns. So if we see that this epithelium is going to be of variability of thickness, and if we use a PTK mode of 50 microns, we are not only removing the epithelium, which is essential of course, of about 38 microns, but we are also topping off 12 microns from the Bowman, which is definitely a very minute amount of ablation as compared to the Athens protocol itself. However, our studies had demonstrated that when we do this, we actually improve the topography of the patient by just changing the way we are removing epithelium. So this is one of the first cases that we had published. You can see this is the pre-operative, this is the post-operative topography showing much more regular topography, and this is the ablation on the Bowman, which is automatically on the steepest areas because of the variability of the thickness of the epithelium that we have in keratoconus. So then we went on to do a study in which we tried to compare the Craton protocol versus the Dresden protocol, and we did this in set of 31 eyes in contralateral study. Of course, this study was done in adults, but just to show you that what is the advantage that this brings in. So in the CXL group, which is the Dresden protocol, we demonstrated no statistical improvement in vision. However, in the TPTK CXL group, which is the Craton protocol, there was a statistically significant improvement in both UDVA as well as the CDVA in these patients. The safety was also seen to be similar, but however, there were more number of patients gaining 2 or more lines on the Snell lens chart. And now we have published recently a long-term publication of this, which is 5-year data of Craton protocol, demonstrating excellent efficacy and safety in long-term as well. So now we have moved on to completely Craton protocol and the Intax in pediatric patients, along with the Dresden protocols. Thank you so much. Thank you.